Hello, good evening everyone. It's a pleasure to welcome you at this EAU organized Urowebinar about prostate cryoablation. Is it ready to really treat prostate cancer? My name is Alexander Govorov. I'm Associate Professor of Urology from Moscow, Russia. It is my pleasure to be a member of the Department of Urology of Moscow State University of Medicine and Dentistry. The chairman of our department is Professor Pushkar, and two main fields of our department are prostate cancer and robotics and female and functional urology. So today we are going to discuss a part on one of these two fields, and namely prostate cryoablation. If you will have a question during this presentation, during this webinar, do not hesitate to use the system allowing you to send your question online. So we will collect your questions and we will try to answer your questions at the end of the presentation. So please write them like you write SMS or comments. Do not hesitate to do it. So let's do this webinar as interactive as possible. Talking seriously, what about cryo? What is this? The definition says that cryoablation is in situ freezing and devitalization of tissues which can be applied and controlled precisely to produce a predictable zone of necrosis that will destroy the target lesion as well as an appropriate margin of surrounding tissue. Goals of modern cryoablation are, first of all, to get accurate cancer eradication. Second, to avoid systemic toxicity. Third, induce local toxicity, but to avoid collateral damage and definitely complications. Cryobiology is not very difficult to understand. You can imagine that, for example, in winter, if you have a glass jar with water and you take it, you put it out of your door when it is -15 outside. In 1 hour or in 2 hours, this glass jar will be broken. The same happens to cells. First of all, the ice starts to form around cells. This is a so-called extracellular ice formation. Then the ice forms inside cells. Then the rupture of cell membrane occurs, and finally there is no more any blood flow in the tissue, and slowly fibrotic tissue forms. So this cryobiology is studied quite well so far by many different scientists. What happens to this prostate cancer tissue, adenocarcinoma of the prostate? Pathologists, they usually tell us that when they evaluate tissue that was cryoablated, they usually see the so-called post-cryoablation coagulative necrosis. They usually say that this necrosis is not really specific, so it is hard for pathologists to differentiate between the necrosis following, for example, external beam radiation therapy and cryoablation. They are looking quite similar to them. But anyway, this is a fibrosis, and if you did cryo and after some time, after 1 year or after 2 years, you are doing a prostate biopsy and pathologists are trying to evaluate this tissue, they see some fibrosis. So it means pathomorphosis from your treatment, from your therapy. We all like guidelines, and I'm sure that EAU guidelines are the best ones. So what do they say about prostate cryoablation? They say that cryoablation is an option other than surgery and radiotherapy for the primary treatment of localized prostate cancer. This is quite clear. Besides, EAU guidelines say that cryo is a minimally invasive procedure with the aim of providing equivalent oncological safety, reduced toxicity, and improved functional outcomes. Finally, it's the new development in focal ablative therapy. I would like to add relatively new. not very new, probably. For those who are not familiar with this technology, I have to tell that to do this procedure, you need a cryo device, cryo machine, you need ultrasound machine, and you need this special rectal probe with a device keeping this probe in a correct place, in a correct position. They call this device brachystepper. The needle to produce the ice is quite thin. It is a little bit thicker than the standard needle we use for prostate biopsy. The needle for prostate biopsy is a needle of 18, and cryo needle is usually 17. So if you are doing prostate biopsies, if you are performing prostate ultrasound, transrectal ultrasound, it is not very difficult to position needles transperineally in the prostate in a correct way to produce the predictable zone of ice formation. There are different types of prostate cryoablation. Prostate cryoablation may be primary, when we ablate the whole gland, means total gland ablation, and it may be focal, primary focal gland ablation. We also use prostate cryoablation as a salvage procedure. Salvage means when we do a local treatment for recurrent prostate cancer after external beam radiation therapy, or after brachytherapy, after high-intensity focused ultrasound, primary cryoablation, or in very, very selected cases, with a salvage cryo, you may treat local recurrences after radical prostatectomy. One necessary condition for this, you have to see this lesion. You have to see this local recurrence on transrectal ultrasound. This is absolutely necessary to use the salvage cryoablation to treat this small tissue. Again, this salvage procedure may be total gland ablation or focal gland ablation. What about indications for cryo? EAU guidelines say that cryoablation of the prostate is indicated to patients with low or intermediate risk prostate cancer whose condition prohibits radical prostatectomy or radiation therapy. And this is quite a clear message. If the patient is not a candidate for radical prostatectomy or external beam radiation therapy, you may consider type of this ablative procedure, like prostate cryoablation. You have a lot of tools to evaluate the patient condition, the patient comorbidities, like Karnofsky status, ECOG score, Charlson comorbidity score, life expectancy tables, and if you put all this together, you use your clinical judgment to decide if this patient is a candidate for cryo or not. What else do the EAU guidelines tell us about indications, about candidates for cryo? They say that candidates for cryo are those having organ-confined prostate cancer. But at the same time, they say that those having minimal tumor extension beyond the prostate are also candidates for cryo. It means small t3. What does it mean, small t3? We do not know. This is not specified. This is not explained clearly in the guidelines. So in my opinion, if you have a case like this is a nice image of prostate histoscanning. If you have a small lesion that is probably a little bit outside the prostate, this patient may also be a candidate for prostate cryoablation. It means minimal T3. Once again, you all understand that this is a very, very subjective judgment. Guidelines say that those having prostate glands less than 40 cc are best candidates for cryo. And there is a recommendation to downsize the prostate with hormones to avoid any technical difficulty in placing cryoprobes under the pubic arch. Well, I am not fully agree with this message and with this recommendation, and I would like to explain you why. If you check the literature about hormones and cryo, you may find papers saying that, for example, patients receiving androgen deprivation therapy before Salvage cryo, especially those with high-risk prostate cancer, they had worse 5-year biochemical progression-free survival. So probably there is some interaction existing between hormones and cryoablation of tissue that we do not fully understand right now in 2016. So if I'm using my expert opinion, do not forget this is a level 4, grade 4 recommendation and personal experience, I would like to say that for prostate cryoablation, there are no usually technical problems with glands less than 80 cc. If you have a large gland, 60, 70, 75 cc, you may use the so-called pull-back maneuver to cover all the prostate with ice. You may select needles to form the larger size ice ball. But if you are at the beginning of your learning curve, so please select smaller glands to make your life easier. Again, coming back to candidates for cryo, guidelines say that candidates for cryo are those not interested in sexual function preservation. This is very important. And those patients with PSA less than 20 nanogram per ml and Gleason score less than 7. This is exactly from the EAU guidelines. For me, less than 7 means 6. Okay, fully agree. We all know that the results definitely are better for those patients having Gleason score of 6. There is no discussion about this. But again, if you go through literature, you may find a lot of papers, both from Europe, from United States, from major experts in prostate cryoablation, and a lot of papers say that, in fact, cancer with any Gleason score may be frozen. So you may freeze Gleason 7, 8, and the tissue will be frozen as well. So think about risk of lymph node involvement and negative metastatic evaluation. This is a take-home message considering this recommendation. What AUA says? American Urological Association experts, they say that candidates for cryo are those men who either do not want surgery or are not good candidates for radical prostatectomy because of comorbidities including obesity or a prior history of pelvic surgery. In fact, in many countries there are a lot of obese patients, very obese patients. Candidates for cryo, according to AUA opinion, are also men with a narrow pelvis or who cannot tolerate external beam radiation therapy, including those with previous non-prostatic pelvic radiation, inflammatory bowel disease, or rectal disorders. How to define success? Good question. We all know the definition of success following radical prostatectomy, PSA below 0.2 nanogram per ml. Is this definition suitable to define success after cryo? I think no, because we do not remove the organ itself. What about post-EBRT definitions? In fact, in many papers evaluating the results of prostate cryoablation, these definitions are used. American Society of Therapeutic Radiology and Oncology, Phoenix definition, Stuttgart definition, many of them have been evaluated. Different authors used other nadir to define success after prostate cryo, like for example PSA less than 0.6, or in several papers PSA velocity more or less than 0.75 nanogram per ml per year was described as a criteria to define the success. Unfortunately, no consensus has been reached so far. What we know for sure when we are thinking about definition of the success? We know for sure that the lower is the total PSA, the better the result. There is no absolute cutoff I mean PSA, for all cases. Please do not forget that if you check PSA 1 day after cryo or 2 days after cryo, it is very high and it reflects the effect of treatment. So there is a very high PSA immediately after surgery, and highly rising PSA or slowly rising PSA not always means the recurrence. So I strongly recommend you to consider to perform, let's say, 1 year controlled prostate biopsy after you did your wonderful and magnificent prostate cryoablation. Even the PSA is very low, even it is, let's say, 0.3, 0.4, 0.5, please consider to perform 1 year prostate biopsy to be sure about what you did. A very nice paper in a health technology assessment has been recently published, namely in 2015. It was a systematic review and economic evaluation about different ablative treatments. For cryo, this paper included almost 4,000 patients. For HIFU, 4,000 patients. For brachytherapy, 26,000 patients. And interestingly, there was no difference in mortality or other cancer-specific outcomes after 4 years. But please remember that this review highlights that there was a very high risk of bias for all studies evaluated. The meta-analysis of biochemical failure at 1 year, 3 years, and 5 years follow-up showed a numerically increased risk of biochemical failure for cryo compared with EBRT at all follow-up points, but this difference was not statistically significant. For the comparison with radical prostatectomy, cryotherapy showed a numerically decreased risk of biochemical failure at 1 year, but there was an increased risk thereafter. Again, none of these differences were statistically significant. If we try to analyze overall survival at 4-year follow-up, there was no evidence of a difference in survival for cryo compared with EBRT at 4 years. Again, there were no data available to estimate survival from the radical prostatectomy study at 4 years. This is a conclusion by Ramsey and co-authors, and I am citing this paper several times because it has been cited again many times at the EAU Guidelines 2016. The meta-analysis of disease-free survival and 1 year follow-up and 3-year follow-up showed a numerically lower rate of disease-free survival for people undergoing cryotherapy than for those treated with EBRT and radical prostatectomy at 1 year. Surprising data. And this was statistically significant. Findings for the 3-year time point were numerically similar to the 1-year results, but the comparisons were no longer statistically significant. What about complications? Complications of primary prostate total cryoablation. EAU guidelines say that in 80% you meet erectile dysfunction. Well, I would say that you have this ED even more often because from the very beginning you select patients who are not interested in preserving their sexual function. Urethral fluffing, 3%. Well, it's a rare complication, and you may mean this complication in case you have the bad function of urethral warming device during surgery, or if you select for cryo the patient who underwent in the past TUR of the prostate due to BPH or open prostatectomy due to BPH, when there is a so-called large TUR defect. Urinary incontinence is quite a rare complication. Pelvic pain may happen, and urinary retention may happen in approximately 2% of patients, and very few of them really require TUR to resolve this persisting urinary retention. The worst complication of primary total cryoablation is the formation of urethrorectal fistula. This is a very rare complication. According to modern data, it may happen in approximately 1 surgery out of 20, 50 cases. But when it happens, I have to tell you, this is a really devastating situation. You have to perform later a colostomy and do a very big and large reconstruction. So during your surgery, please do all precautions, do all maneuver to prevent the freeze of the rectum wall, to avoid this rare but very serious complication. What about urinary function after cryo and quality of life? Very recently at the AUA meeting in San Diego in May 2016, we have presented a trial performed in our Department of Urology. The aim of this trial was to prospectively evaluate urinary function changes after cryosurgical ablation of the prostate in men with clinically localized prostate cancer and pre-cryo mild and moderate to severe LUTS, and to assess risk factors for urinary function deterioration after surgery. In this trial, we assessed urinary function with IPSS and quality of life index scores. We assessed post-void residual volume and maximal flow rates in almost 100 patients with mild and moderate to severe LUTS after primary and salvage prostate cryoablation. Hopefully, there were no cases of urethrorectal fistula formation, and only 3 men reported post-cryo stress urinary incontinence. Evaluating all these questionnaires, we have demonstrated that cryosurgical ablation of the prostate negatively affects urinary function during the first year after surgery, with subsequent gradual improvement up to 2 years follow-up. Again, surprisingly, patients with basic severe LUTS and larger prostates, they had greater improvement after 2 years. And moderate to severe LUTS that are very, very prevalent in older men are not the contraindication to cryosurgical ablation of the prostate in 2016. What about salvage cryo? Salvage total cryoablation results. Here I'm showing you the table taken from the EAU Guidelines 2016, and you may see that probability for men to be biochemical recurrence free varies from 34 to 73%. It depends on what definition you use and how long do you follow patients after surgery. Perioperative morbidity is definitely higher when you compare this type of treatment with primary cryoablation, and namely incontinence you may meet much more often than when you do primary total prostate cryoablation. Coming back to our experience, I have to tell you that salvage type of prostate cryoablation, at least in our department, is the only one significant factor of urinary function deterioration. If we try to summarize who are the best candidates for salvage total cryo, these are patients with low comorbidity. These are men with life expectancy of at least 10 years. These are patients with initial organ-confined prostate cancer. Initial, I mean before first treatment of prostate cancer, Gleason score 7 or less, and men with pre-salvage PSA doubling time more than 16 months and PSA less than 10 nanogram per ml. And please do not forget, if you consider to use this salvage local treatment of the prostate, you have to prove that there is a true and real local recurrence. So all these men, they have to undergo the control biopsy before you take the decision about salvage prostate cryoablation. Just a couple of words about focal cryoablation. if you did your beautiful transperineal saturation biopsy using this template like sea battle, and you are quite sure where your cancer is localized, you may easily put your needles in a region of interest, and you may easily freeze either 1/2 of the gland or even 1/4 of the gland, providing very high chance to cure the man from small prostate cancer. Coming back to this systematic review by Ramsey and co-authors, this review says that if you compare focal cryo versus radical prostatectomy or EBRT, there is no statistically significant difference for biochemical recurrence at 3 years. After focal cryo, incontinence rate at 1 year is very low, less than 1%. ED rate is similar to radical prostatectomy. I am very surprised because in my experience, after focal cryo, there is almost never any type of ED because we preserve nerves very, very well. And finally, procedural complications of focal cryo are quite low. The commonest one is a urinary retention with range of 1 to 8%. In summary, EAU guidelines say that no reliable long-term comparative data indicate in 2016 that cryo leads to equivalent oncological outcomes compared with radical prostatectomy or external beam radiation therapy. Please remember that this is a level 3 evidence. PSA nadir values after ablative cryo may have prognostic value. Focal cryo appears promising but remains investigational, and please offer and discuss salvage cryo to patients or with patients without metastasis and with histologically proven local recurrence. Just adding some small evidence or some small type of expert opinion, which is level 4 evidence, I would like to add that radical prostatectomy and external beam radiation therapy are best treatment of prostate cancer. For sure, there is no discussion about it in 2016. But if you are working in a big center, having a lot of patients with prostate cancer, having a lot of patients with comorbidities, different patients, there are always prostate cancer patients that need other options other than surgery or radiation therapy. So please consider cryo for total primary, salvage, and focal therapy. And despite all the available evidence, expert opinion is still here in 2016. So please do not hesitate to ask experts or your chief or your friends or your colleagues having some experience. Okay, this is all for lecture. Thank you very much for your attention. It was my great pleasure to give this talk, and right now we are going to try to address questions we have received from some of you. Sergey Sukhikh, a fellow of our Department of Urology, is helping me right now, and I am asking him if we have interesting questions so far.
Yes, Professor Govorov, thank you for your presentation. We have got a lot of questions. We chose the most interesting questions. For example, Don Davis from UK is asking, what type of anesthesia do you use? And is it possible to do cryo with local anesthesia?
Thank you, Sergey. I have heard some echo from your part. So I would like to repeat this question to the audience. The question was, what type of anesthesia do you use? And is it possible to do cryo with local anesthesia? This is a question from UK. So for cryo, you don't need any general anesthesia. We usually use spinal or epidural anesthesia, and definitely it is not possible to do prostate cryoablation with local anesthesia. We do kidney cryoablation as well, and if you select laparoscopic approach for kidney cryoablation, you need a general anesthesia. If you select to do a kidney cryoablation under ultrasound control, you may use some form or some type of local anesthesia, but never for the prostate. So for the prostate, we need spinal or epidural anesthesia. So I see a list of questions in front of me. The next question is asked by Michael from Italy. There is no family name here. Michael is asking, is it possible to restore erectile function after total gland ablation with PDE5 inhibitors? Good question. It's a pleasure that people from Italy are interested in erectile function restoration. I would like to answer you from a little bit other side. First of all, we do not recommend to select for total prostate cryoablation those men who are interested in erectile function preservation. So if a man keeps his erection, he has to be considered as a candidate for focal cryo or for radical prostatectomy, because once again, total gland ablation is not a good way to prevent, to restore erectile function. So if you did a good total prostate cryo and you have frozen urovascular bundles, I doubt that best PDE5 inhibitors will help this man. So next question has no author. This is a question: what other treatments of prostate cancer do you use in your center? So once again, maybe this is a question from one of the participants who didn't follow us from the beginning. I am working at a very big department of urology. This is a department of urology of Moscow State University of Medicine and Dentistry. We have almost 200 beds for urology, only for urology. So to treat prostate cancer patients, we are using robotic prostatectomy. At present, we have 2 robots. We are using definitely open prostatectomy. We are using prostate cryoablation, and we are using brachytherapy. In our place, we don't do external beam radiation therapy. It's close to us, but not in our hospital, and we don't use HIFU. For sure, we use active surveillance as well. Any other questions, Sergey?
Yes, we have one question. Any role for cryo in CRPC?
Okay, challenging question. Any role for prostate cryoablation in castration-resistant prostate cancer patients? Well, if you follow guidelines, there is no place to treat these patients with prostate cryo, from one side. From the other side, since many years, for us urologists, metastatic prostate cancer patients, they were candidates for only hormonal therapy. And right now we are running trials evaluating the role of radical prostatectomy in these so-called oligometastatic prostate cancer patients. So who knows, probably in the future, even in castration-refractory prostate cancer, we will use some type of ablative local therapy like cryo or HIFU to treat the tumor itself. Not in 2016, but in the future, probably yes. What else, Sergey? What other questions do we have?
I have one question from Tom from England. What type of biopsy do you use 1 year after cryo? Is it different in total and focal cases?
Once again, after total prostate cryoablation, after 1 year, we do control prostate biopsy to all men. Usually it's a transrectal ultrasound-guided 12-course biopsy. We're doing this biopsy under prostate histoscanning control. I would say that this type of biopsy is quite similar for both men after total cryoablation and focal cryoablation, because even if we did focal procedure, we still do a biopsy involving both lobes of the prostate, treated and non-treated. So in a small window, I see one more question. This is a question from Derek Sommer from Munich, Germany. He is writing, several times it was very difficult for me to put the urethral warming catheter. What do you do to put it in the bladder? Good question. Good question. Experienced people know that the urethral warming catheter is very rigid. It's quite stiff. So this is true. In some cases, it is not very easy to put it in a bladder when needles are in the prostate. So we use a guide wire. This guide wire goes through the flexible cystoscope in a bladder. Then we take the flexible cystoscope out, and the guide wire is still in urethra. And we try to pass this guide wire inside the urethral warming device. And at the time when, for example, I'm putting this urethral warming catheter in, my colleague, my friend who is assisting me, he's doing this maneuver with a traction of the guide wire, and it facilitates the insertion of urethral warming device. This is how we do it in our center.
Professor Govorov, we have one question. Have you ever performed a radical prostatectomy after cryo?
Have we ever performed radical prostatectomy after cryo? Again, it's a good question. We have performed several robotic prostatectomies in patients who underwent in the past focal cryoablation and had a biopsy-proven recurrence. I have to tell you that that on the site where the prostate was frozen in the past, it was quite a difficult surgery, very similar to the surgery after EBRT or brachy, but in general all surgeries went well, and remarkably in all cases we did in our department, when we performed salvage radical prostatectomy after focal cryoablation failure, we didn't find any cancer in frozen region of the prostate. All the recurrences were detected in the non-treated lobe. So I think we don't have any questions so far. I would like to thank all the participants of this webinar. It was a pleasure to share the discussion about prostate cryoablation with you this evening. Thank you very much, and goodbye.